further ado, let me start with introductions. Well, with the introduction of Flavio. Flavio Toxvaerd is university lecturer at the Faculty of Economics at Cambridge. He's a fellow of Clare. He's been at Clare since 2005. He specializes in microeconomics and applications. He has for many years done research on the economics of infectious diseases, publishing both in economics and biology journals. In addition to his academic work, he is engaged in policy formulation as the senior economic advisor to the Independent Review on Antimicrobial Resistance from 2014 to 16, which was jointly set up by the government and the Wellcome Trust, and has also advised the government on issues such as social distancing and vaccination. Since 2016, he has been a member of the academic panel of the Competition and Markets Authority. This evening, he's going to talk to us on a talk entitled Economics and Epidemic, Models, Behavior, and Policy. So welcome to everybody, and welcome, Flavio.
Thank you very much. Am I unmuted?
You are.
Okay, great. Okay, thank you very much, Bill. That's very kind of you for inviting me, and thank you everyone for coming today. So, my goal today. Sorry, my cable of my mic just got tangled in my chair. My goal today is to give you a bird's eye view of the kind of work that I and other people in this discipline have been doing over the past 50 years. So this is a discipline or an interdisciplinary field of research that started in the 1970s, but really took off in the 1980s with the HIV/AIDS epidemic, and then more recently, of course, has gained more prominence and probably also more urgency than it has previously, and therefore maybe this is a good time to take stock at what we have learned so far and why this is useful for people outside of this field to know a bit about. So let me just start by giving a little bit of background. It's probably not necessary. The fact that we're doing it in this format already should be a kind of motivation enough, the fact that we're not together, but let me just run through a few bullet points. So currently we are facing a very serious global crisis with the COVID-19 spreading across the world. Now, this is unusual in that it is in fact two intertwined crises. There is a direct health crisis, which is of course the fact that people get infected and get ill and even die. But there is an intertwined crisis, which is an economic crisis that comes because of the fact that the way we have been able to, or the only way we have been able to respond to this crisis has been one that also damaged the economy at the same time. So rather than thinking of two different crises, I like to think of them as two faces of the same problem. You cannot really look at one without the other. Now, until very recently, for this particular epidemic, we haven't really been able to rely on pharmaceutical interventions such as antiviral drugs and vaccines. Antivirals are now coming online, and we have recently received very encouraging news about at least two or at least three highly effective vaccines that will most certainly be a game changer going forward. But until now, we have been relying almost exclusively on what is called non-pharmaceutical interventions, or NPIs. And NPIs, or these kinds of interventions, are basically interventions that are designed to create distance between individuals. And so by doing that, we slow the spread of the disease. So these are self-isolation orders, quarantines, lockdowns. In the US, they're known as shelter-in-place orders, but also other policies such as closure of schools, workplaces, places of worship, and so forth. So what all these interventions have in common really is that they reduce the contact rates, and by doing so, retards or curbs the spread of the disease in the population. Now, because these are interventions that are essentially behavioral, that is, either they rely explicitly on the government telling people to voluntarily socially distance, or they consist on mandates that tell people that they mustn't do specific things, then a key in understanding the extent to which these kinds of policies are effective is to understand behavior itself. And I found a nice quote here. This is a congressman that I think has just stepped down. He said, Epidemiologists cannot know the specific actions of each individual in a community. And this is the kind of knowledge that is beyond, of course, any scientist. Okay. Now, this is exactly the margin on which economists feel that they can contribute something to this field. So the behavior is really the key thing. So what does economics have to do with it? Maybe, I don't know whether this is necessary for this particular audience, but many people are under the impression that economics is all about investments, or it's all about the economy, or some such thing. Economists themselves think of their field as a much more expansive field. There's a nice quote here by Alfred Marshall, who was, of course, an economist here in Cambridge. He said that economics is the study of mankind in the ordinary business of life. So in principle, there's nothing that is beyond the scope of economics. And so just so happens that economics has a very well-developed toolbox for trying to get a handle on behavior of individuals. Of course, there's a whole range of different approaches that have been taken, from the fully rational to the boundedly rational and everything in between. For example, behavioral economics looks at the decision-making with the behavioral biases, but there's a fairly well-developed toolbox that in principle we can use to bring to bear on trying to understand problems of behavior during an epidemic, which you might otherwise not think of as an intrinsically economic problem. Okay, so before we go into the nitty-gritty, let me just show you a few historical examples of where people have actually behaved in different ways in order to avoid becoming infected. This is a particular, an illustration of Decameron, of the Black Death in Florence. And you can see this in this quote, that the Black Death made people shun and flee from the disease in order to protect themselves. If you recall, the Decameron takes place in the mountains outside of Florence, where a group of people who have sought refuge from the disease tell stories to each other, and that's just one instance, of course, of social distancing. A later depiction here, these are townspeople fleeing the disease in a carriage, and I think it's interesting to note that there seem to be already death seems to be traveling with them. I like to think of that as maybe being asymptomatic infection amongst them that they still don't know at this point in time. Okay, so let me take you back to March 2020. So in March 2020, the disease had already started spreading. People were well aware that something was happening, and it was quite clear early on that the overriding policy objective, at least in the UK, but in most other countries, was to do what is just termed flattening the curve. So what exactly does flattening the curve mean? So this particular infographic, this is not one that I have created. I think it originated with the Economist magazine, but some version of that has been making the rounds for many months. So what is this supposed to show is that if left to its own devices, that is, if there were no intervention, then the pandemic would have this kind of pattern. Okay, so a very steep increase and a peak prevalence which might overwhelm the health system, the NHS in the case of the UK. And so the overriding policy objective became to make sure that we stem the disease to the extent possible so that we do not overwhelm the health sector. And this is basically what flatten the curve means. Now, in March, there was a report that was released by a group led by Neil Ferguson at Imperial College London, and this is perhaps the single most how can I say this? This is the scientific report with the largest direct policy impact that I can at least recall. So this is a headline in the Financial Times: the shocking report or study that rocked the UK and the US. So let me just take you back to that point and show you some of the things that came out of this report. This is again the Financial Times rendition of the information in that report. But basically, what that report said is that in what they called the reasonable worst case scenario, that is, if there is no intervention and if there is no spontaneous behavior, then the UK death toll could be as large as 510,000. So 500,000 people dead in the UK, and similar kind of simulations for the US suggested there might be more than 2 million deaths. So this is, of course, the kind of numbers that get people to pay attention. Of course, no policymaker or public health authority can ignore those kind of numbers. And so it's kind of interesting to understand exactly what is the meaning of a worst case scenario. It turns out to be a technical term that is used within epidemiology and that does not export well to the wider public, because we might disagree with what exactly is meant by the word reasonable. So if you dig into the report and that you see the results that they present, then you see that they are actually quite careful in interpreting their own results. What they said is that in the unlikely absence of any control measures or spontaneous changes in behavior, then we would predict these 510,000 deaths. So they're quite clear in the report that they themselves consider this to be a very unlikely scenario. And that's also why epidemiologists are at pains at not calling this a prediction. They use words such as scenarios or projections or some other thing, and they offer this as a possibility of something that can happen, not necessarily what will happen, and not even what they think will happen. In fact, subsequently, Ferguson has publicly stated that they never thought that this was a realistic scenario. Okay, the problem is that those caveats were completely lost in the subsequent media coverage, and those 510,000 were actually taken as a prediction, and as such actually caused a large number of problems subsequently, because people lost faith in the expertise, because numbers nowhere near those numbers actually materialized. Okay, so let's do a last thing before we get back to the real world. In that report, they suggested a number of different interventions that they basically offered as possible things that policymakers could do. And there were a whole range of these interventions. Some of them had to do with school closures. Some of them had to do with voluntary home quarantine and so forth. And let's just take that for simplicity. So that's the policy HQ. Following identification of a symptomatic case in the household, the whole household stays at home for 2 weeks. And then they assume that 50% of households comply with the policy. The problem with this is that there are actually no people in their model. The models that they work with are as useful for studying non-human populations like cattle or plants as they are for human populations, because the actual decision-making of individuals has not been explicitly modeled. And so what we end up with is this kind of scenarios where, you know, we just guess that 50% is going to be complying with this policy, but we don't know whether 50% really is realistic, whether we should look at 90%, or whether we should be looking at 10%. Now, one thing that has been very interesting in this last epidemic is that there has been an incredible torrent of new sources of data that we can actually bring to bear on our analysis of actual behavior. And this is an example that did not exist in the past. This is what is called Google mobility reports, community mobility reports, I think they were called. And these numbers basically show the time spent by people in different locations relative to the same locations last year. So this particular graph shows the case of Copenhagen, the capital of Denmark. And you can see that somewhere around the first week of March, there's a shift in behavior. Suddenly, people start spending much less time in retail and recreation. They start spending much less time in train stations and groceries, pharmacies, and in the workplace. And similarly, there's an uptick in activity that takes place in the home, and also similarly, more people spending time in parks, presumably because in parks people can be more distant from others. Now, there's just one thing I want to note here is that this decrease in the activity in venues that are potentially conducive to the spread of the disease actually happened before the formal lockdown was introduced in Denmark, which was on March 13th. And just to hammer home that point, let's look at the same data for Sweden. So this is now for Stockholm. And the reason I'm showing Sweden is twofold. First of all, it's comparable to Denmark in many respects. Socioeconomically, it's very similar historically and also in a number of other respects. But the more important thing to note is that Sweden is famous for having taken a fairly non-intrusive approach to social distancing, whereas Denmark had a strong, strict, centrally imposed restrictions on social activity. In Sweden, the government did recommend that people socially distance, but the important thing is that there was no compulsion. And so you see the same patterns in Sweden as you see in Denmark. Let me just flick back. If you want to compare the orders of magnitude, just say transit station is minus 45% in Stockholm and minus 67% in Denmark. So we can see that in Sweden, there was clearly behavior change. There was a movement towards voluntary social distancing, but clearly the magnitudes are not quite the same as the ones that were in Denmark. And that just goes to show that actually imposing them does make a difference. But the point here I want to make is that even absent any compulsion, there will be some movement towards self-protection. Okay, so let's now move on to how economists think of infectious diseases and how do we use our toolbox for understanding this kind of situation. So an economic epidemiological analysis has two building blocks. The first one is an epidemiological model, which is completely identical in principle to the kind of models that epidemiologists use to make their predictions. So for example, the kind of models that I work with are like the kind of models that the Imperial Group work with. Of course, theirs are infinitely more complicated because they have contact patterns, they have all sorts of bells and whistles, but at the very base, they're very similar type of models. Now, what economists then do is, rather than assume that people are automata or are like cattle and they don't actually make decisions in the model, what we do is we build a behavioral model on top of that, or an economic model, and we use that behavioral model together with the epidemiological model to try to get a grip on how people will behave in this model when the conditions change. And by nesting the behavioral model within the purely biological model, what this allows us to do is two things that are kind of interlinked. On the one hand, we can understand how each individual behaves as a function of what happens at the aggregate level. That is, we can see how each individual behaves in terms of self-protection in response to changes in the entire population. And at the same time, we can understand how the aggregate evolution of the disease is influenced by decisions made at the microscopic level, that is, at the individual level. And it turns out that this interplay between the microscopic and the macroscopic is one that is very, very well known to economists. They study this kind of interactions as a matter of course when they study macroeconomic phenomena like inflation or unemployment or any such thing. Okay, so doing this will bring us to a point where we can better understand behavior in this kind of context, and it is hoped, of course, also help and inform policies of disease control. Okay, so let me take you through the model. I'm going to show it to you very schematically. So this is a classical model of epidemiology. It's called a compartmental model. And what it does is basically it splits the population up into different buckets depending on their current health state. So in the simplest version of this model, there's a constant population without growth, without inflow of people, or without deaths. And there are three compartments: susceptible, infected, and recovered. I should note that as soon as you write down this model, you've already made an implicit assumption about what kind of disease you're looking at. So we still don't know whether the COVID is an SIR model or whether there is waning immunity, and therefore people eventually will make their way back to the susceptible class. But this is schematically the kind of model that many people have been looking at recently. The epidemiologists have recently worked So for example, SPIM, the modeling unit that advises SAGE, they all work with SEIR model, where they split the infected into exposed and infected. But these are variations on a theme. Okay, so if you run an SIR model, so SIR stands for susceptible, infected, recovered. If you run this kind of model, you will typically get a pattern of disease prevalence that looks something like this. So basically, this shows that for a long period of time, there's not much happening. There's a few people infecting other people. You're hardly going to notice it. But at some point, this effect kind of snowballs. Each person infects more than one other person. And at some point, there's a very dramatic increase in infections. Luckily, because people recover and therefore become at least temporarily immune to additional infection, there will be a point at which the epidemic peaks, and then over time, it will peter out. So this is very much like the kind of pattern that I showed you earlier. Okay, now what's the problem with this? So what's the problem from an economist's perspective with this kind of analysis? Well, the problem is that it is the implicit behavioral assumption is that individuals behave in exactly the same way at early stages of the epidemic as they would at later stages of the epidemic. So if you just go back 1 second, can you see my cursor, by the way? When I do this, can you see this? Yeah, okay. It basically presupposes that individuals who are at this stage of the epidemic behave no differently than they would up here. But we know, of course, that that's not true. We know that people do something to change their behavior, and this is exactly what we wish to capture. Okay, and this is also where economics comes in. So let me just take you back to our old friend Marshall again. So Marshall, he formulated something that is almost so trivial that people might not even know that it has a name. It's called the law of demand. And the principle is one of the fundamental ones in economics. And it tells us that under normal circumstances, there are exceptions, but on the whole, as the price of a good increases, the quantity demanded of that good decreases. So for example, if restaurants suddenly double their prices, well, fewer people will go out to eat, something like that. Now, what we really are doing here in economic epidemiology is we have this law of demand, and we are basically applying it to the decisions of individuals facing the risk of infection. So what's the good here? The good in question is basically the social activity or the potentially transmissive behavior. So think, for example, going to the theater is a thing that you like doing. The price in this parallel in this situation is, of course, the risk of becoming infected. And so what this tells us is basically that as the risk of infection goes up, then the demand for that particular activity is going to go down. Okay, the economic epidemiology incarnation of this law of demand is known as prevalence elastic behavior, and that's just a fancy way of saying that as disease prevalence in the population increases, so do the risks involved in transmissive behavior. And therefore, those risks, as they increase, they're going to give people an incentive to scale back on those behaviors. Okay, so the behavior is elastic, it changes with the prevalence. Now, there's one little twist, of course, which is that the behavior in turn also determines disease prevalence. But because what is prevalence after all? Prevalence is just the aggregate of infection of lots of individuals. So in the same way as prevalence influences individual behavior, so individual behavior also influences aggregate disease prevalence. Okay, so if you write down a model, a very simple model will do, then you can then try to predict what is going to happen if people can self-protect. Okay, and then you get something like this. Okay, so this shows you in the black curve is the curve that we had from before. This is the no behavior benchmark. And in the blue line, I have plotted the equilibrium disease prevalence when people can spontaneously self-protect. Okay, so the important thing to note here is that there is no coordination between individuals. People just do what is best for themselves. So there's no coordination. People are self-interested. They don't flatten the curve, quote unquote, because they want to do anything about the population. They don't want to necessarily not overwhelm the health services. This is all comes from the incentive of individuals to self-protect. And I haven't shown you the graphs for the social distancing, but let me just show you what happens here is that in the beginning, the two curves coincide because the risks are still fairly moderate. At some point, though, the risks become less palatable from the perspective of individuals. And what happens then is they start scaling back their exposure. And by doing so, they actually curb the extent of additional incidence and therefore prevalence. And so what happens here is that you get some flattening of the curve, even without any public intervention at all. Okay. So, so that's the first thing we want to note. So what are the main kind of insights of this exercise? By the way, this is an old insight that was already identified in the 80s in the context of HIV, which is that people will generally seek to self-protect because they care about their own well-being. And so the purely biological model, which might be appropriate for non-human populations like cattle, or which might be acceptable also for, say, a population of plants, may not be appropriate for a situation where people make decisions, okay? And so there are two specific drawbacks from using the epidemiological approach blindly. The first one is a matter of projections. The so-called reasonable worst case scenario will tend to overstate disease incidence relative to what will actually happen if people self-protect. So that's the first thing. The second thing is perhaps even more important, which is that the purely biological model, by not drilling down on people's incentives and trade-offs, offers only a very limited understanding of what would the effects be of different policy interventions. So for example, if Rishi Sunak goes out and says we're going to increase statutory sick pay, the biological model has almost nothing to tell us about that. And this is something we're going to come back to a bit later. Okay, now one thing that I think is extremely important, especially in these polarized times where people are either for lockdowns or completely against lockdowns, I don't want you to get away with I don't want you to leave this with the impression that we don't need to do anything because people are going to solve the problem on their own, okay? This is not the case. And the reason is that in this kind of models, there are so-called positive external effects. So what this means is that if I protect myself, I basically protect myself by staying away from other people, then I reduce my own risk of becoming infected. But by reducing my own probability of becoming infected, I also indirectly protect the people in my household, or people that people in my household get into contact with, and so on and so forth. And so there are strong positive externalities from the social or self-protective behavior in this type of models. Now, to the extent that people are completely altruistic, all these positive externalities are, of course, realized and everything's great. Now, short of this kind of perfect scenario, we know that people are at least partially selfish and therefore might not fully take into account what these positive social effects of their self-protective behavior may be. And for that reason, there will typically be less social distancing in equilibrium, that is voluntarily and in a decentralized and uncoordinated manner, than would be socially optimal. Okay, but we can actually run the model again and ask, well, suppose that the benevolent social planner or a health authority could tell people what would be the best thing to do while keeping in mind these external effects. We can actually run this model again, and then we get something like this. Okay, and this shows you basically that what we call the socially optimal path of disease prevalence in this model is actually lower than what will happen in equilibrium. And so that, in some sense, gives us a ranking of the three different scenarios. The no behavior benchmark that the epidemiologists work with is probably overstating the problem. But what the ranking between the blue and the red curve shows us is that there's no sense in which people are going to solve the problem on their own unless they're given the right incentives to actually to actually put in the self-protective behavior that is needed in order for society as a whole to be better off. So this is actually a perfect segue to talk a little bit about incentives and talk a little bit about what are the effects of different economic policies. Okay, so recently, or actually over the last many months, that there's been a number of different initiatives that you can think of in principle as being fiscal policy. Okay, so for example, statutory sick pay, furlough scheme, job support scheme, eat out to help out, and a number of other initiatives of that kind. So these are almost exclusively, or almost these are policies that always come out of the Treasury. Now, there was a very interesting meeting of the was it the Treasury Oversight Committee or something like that, where the chief economist of the Treasury was actually pressured to justify some of these measures, and was asked explicitly whether impact study had been carried out on these measures, and they actually confessed, or they actually owned up to the fact that many of these policies are actually not carried out with an explicit view of what these might have as of impact on the disease itself. They're all thought of in terms of classical economic policy, in terms of supplementing incomes and so forth. Now, it might not be a surprise that these policies actually also, they also actually influence people's incentives. And to the extent that they influence people's incentives, they actually also has an important impact on the evolution of the disease. So, for example, statutory sick pay. We know now from self-report, from empirical work, that the more generous the statutory sick pay is, the less likely are people to go back to work despite having symptoms. So, for example, some of the countries we'd like to compare ourselves with, like Germany, for example, or in fact Sweden, which we usually would like to compare ourselves with, maybe not recently, they have much more generous statutory sick pay. And so you can think of that as being a missed opportunity for an economic policy actually to do its bit to reinforce a good health policy. Now, but the fact that they are in place, that the job support scheme is in place, is certainly something that is worth mentioning as a plus, but we can then, agree or disagree about whether it's set at the right level. A policy which I think universally, at least by many economists, is viewed as being ill-conceived is the Eat Out to Help Out scheme. So this is a policy that was introduced ostensibly to help out the hospitality and restaurant sector. Okay, these were clearly sectors that were under great duress because they had been closed down for many months, and we wanted to give them a helping hand so that they would weather the storm and get through to the other side. And of course, this is a laudable aim. The problem is that that kind of support could have been achieved in a different way. It could have been achieved by just giving direct transfers to that sector, rather than encouraging people to go at taxpayers' expense to expose themselves unnecessarily to additional infection. Now, there is at least one empirical paper that offers some preliminary evidence to suggest that it actually helped increase infection, but this is still not a peer-reviewed research, and so we will have to see whether this is actually a robust finding. But even if that were not the case, you can see how this creates all the wrong incentives. Now, the idea of externalities, I just want to bring up in another context, which is that in the same way that individuals have external effects when they decide to self-protect, so do any other decision-making unit. For example, a city which falls under tier 3 restrictions will basically have to close down. And so we had this case of Manchester where local government said, we are happy to close down because clearly our infections are out of control. But what they actually insisted on was more generous support from central government. They held out as long as they could, but in the end, the central government actually went ahead with the close down without local coordination. Now, I'm not going to argue about the numbers, whether they got the right amount of money, but I think there's an important principle to keep in mind here, which is that when Manchester closes down its economy in order to stem the spread of the disease, they're actually providing a public good. And the reason is that if disease in Manchester is completely out of control, that will have a spillover effect on all the regions around it, and eventually it's going to be everyone's problem. So in the same way that we want to incentivize individuals who test positive to stay at home and take an economic hit, and we want to support them by giving some kind of transfers, this is also true at the city level. Okay, so it's not, so this idea that there are positive externalities and therefore we should actually pay people to provide those externalities, this is sound health policy. This is not just a matter of economic policy. And so when you calculate these transfers or these support schemes, you shouldn't just keep in mind the traditional reasons that are given for these kind of transfers, that we want to give people unemployment benefit. There's an added value here, which is that it also helps us actually stem the disease. Okay, but once, of course, and let me just summarize this thing with the incentives. It also, this framework of looking at cost and benefits and individual trade-offs, of course, also allows us to study things like incentives to get vaccinated, incentives to get treated or tested, and a number of other measures that are useful here for disease control. Okay, so in my opinion, economic epidemiology really shows us that we need to have a shift in approach in combating the disease. You cannot disconnect the study of the epidemic from the study of the economy. Because the measures we have at our disposal, social distancing, reaches deep into both spheres, both into the epidemic and into economic activity, you cannot disconnect these two things. They are one and the same problem with two different manifestations. So it's not good enough to have the epidemiologists sitting with no input from economists, dreaming up different restrictions, and then having the economists, on the other hand, you coming up with great ideas about how to support different sectors, but not keeping in mind that those might actually impact the course of the epidemic. You cannot have those two things so those two groups of people looking at this problem from different perspectives. And let me just finish by saying that most economists, not all, but most economists, they reject this idea that what we're facing is a health versus wealth thing. We don't believe that there is any sense in giving up on health in order to get businesses going. We don't think that we can have a healthy economy when people are ill. And looked at it from that perspective, getting the epidemic under control is actually the best way of getting back to a normal kind of life, that it will also have good effects on our social and on our economic lives. So I think that's what I had planned to say.
Thank you, Flavio. And I now want to invite people to raise their hand to ask questions or to put some questions in the chat, or members of my team, if you want to turn your screen on, we'll even look for people who are sort of waving in their windows at us, and we'll try and call on people. But let me start off, Flavio, by just asking you, I mean, you've been working in this field for a long time. You've been thinking about this. Obviously, there have been infectious diseases and more localized, but this is, though, hopefully once in a century event. What has surprised you, when you look around the world and you see prevalence, different in different countries, what are some of the different models, where you see just different scenarios that have played out, and what lessons do you think you'll be drawing from this over the next 20 years?
So I hope that this will be a turning point, that we will, going forward, we will be better prepared. I think, I don't think that this is something I can tell that epidemiologists have always been interested in these things. Economists have been much, much less interested. I think in many people's minds, this has been a third world type of problem. This malaria is something that happens in other countries. It is not something we need to concern ourselves with too much. Of course, HIV is the exception because that hit very close to home. I think a lot of researchers will, going forward, will probably look at this kind of situation with a little more interest than they otherwise would have if this hadn't happened. I like to think of the field of economic epidemiology a little bit like natural resource economics or climate change economics, that for many, many years, there were people at the periphery of the discipline working on this. And at some point, the discipline as such realized that this was actually a very important problem. And so I hope there's going to be lasting interest in these. And you say it's a once in a century thing. The epidemiologists seem to be, and now I'm not an expert on this, but they seem to disagree that these things are going to be recurrent. Now, whether it's going to be worse or better than the current situation, I don't know. But I think certainly we should think carefully about creating robust institutions so that if this were to happen again, we are better equipped, we have better test and trace capacities, we have a lot of different things in place so we can mitigate the effects of eventual lockdowns if they need to happen. For example, making sure that all kids have a laptop so that if we need to close down, no kids will have to go 3 months essentially without schooling. So there are lots of things we can do that have intrinsic value, but also makes us better prepared if we were to face a problem like this again.
Thank you, Flavio. So there's some questions starting to come into the chat. Karen asks 2 questions, and I'll read them both to you. Are the optimizing agents forward-looking? And can you fit the blue curve by modifying the basic reproduction rate of the black curve without adding optimization?
So the first one, in all my models, they are always forward-looking, but that's not always the case in the literature. So there are models also where people are myopic, and in some sense you can think of that as 2 different extremes on a spectrum of cognitive abilities. So some of them might be very sophisticated and forward-looking, and some are less so. I should say, though, that those big points that I pointed out today, none of those depend actually on that assumption. So this thing about people having a stronger incentive to self-protect when infection goes up, that's going to be true whether you're forward-looking or not. It's just the strength of that effect is going to be different. Now, whether you could recreate the blue curve, sorry, it was the black curve with the blue curve, it's quite possible you might be able to finesse the parameters so that you would achieve those 2 functions coinciding, but I kind of not see the point of that, because the reason they're different is that there's a fundamental difference in modeling approach. And so it's not that we're trying to recreate one with the other. Really, we're taking a different methodological approach, which then leads to these differences. If it turns out that the outcome of our new model coincides with the old model, in some sense, our new model in innovation would have been in vain.
Thank you, Flavio. So John asked a slightly political question, perhaps.
Sure.
So your final remarks indicate quite strongly that the arguments of the COVID recovery group among Tory MPs, Steve Baker et al., are profoundly misguided.
Well, so first of all, in my public writing, I always emphasize that this is an issue of trade-offs. So there are trade-offs, and in my model, you can, if you put in the right parameters, you can easily get that we should have almost no restrictions. But you can also get that we should have much, much stronger restrictions. So the real question is not whether people agree with my particular methodological approach, but whether we agree on the parameters. Our main problem now is that we do not have a well-developed and credible framework for doing cost-benefit analysis. This is something that I think the government should carry out, because the know-how in some sense is available. So there have been sporadic attempts to do cost-benefit analysis. We can nitpick about the details, but I think the only way we can really get away from this very polarized notion of for or against lockdowns is to have a non-politicized and in some sense common framework for understanding these things, let's run the analysis, and then that's going to, in some sense, take out the sting of this debate. I think it's profoundly unhelpful that people have decided we're against lockdowns, and because we don't have the lockdowns, we demand a cost-benefit analysis. Because the recent decisions have been made in this country since 2016, where people agreed with those decisions and no cost-benefit analysis was asked for in those particular instances. So it seems to be the wrong way around. We demand cost-benefit analysis when we don't agree with the decisions, but otherwise, you know, a rough estimate is good enough to make our decisions.
Thank you. I think in a way that answer addressed Nigel's question, which was next in the chat. Nigel, I'll come back to that if you want, or if you want to ask it a slightly different way. I think that what Flavio said sort of gets to that. Peter asks, can I ask you what you think about your colleague Andrew Harvey's modeling approach and that of David Henry at Oxford, which jettisons the epidemiological approach for the econometric approach?
So look, I am an economist. I'm not a statistician. I'm not a econometrician. I understand that, that I have a great respect for them, and so I am happy that they do what they do. This is not my cup of tea, or rather, this is not my approach to things. The econometric approach makes it difficult to understand policy interventions, I feel, but I think I see Peter strongly disagrees. But I should also say that I'm not super familiar with the work, and so I don't want to be too dismissive. But so yeah, can I ask you, Peter, what you?
Yeah,
I don't know whether I'm allowed to invite somebody.
I disagree because I've also spent the whole summer working on exactly the same sort of models. But where my work differs from theirs is that I've been taking on board the data that's been collected by Oxford, which is country-specific data on all of the policies on a day-by-day basis. So we're actually controlling in a very clear way for all the policies and their timing of policies in, broadly speaking, the same kind of model that David Hendry or Andrew Harvey's been following, and actually comes out with very interesting results about which policies are actually effective. So it's a reduced form kind of approach, but I think it takes on board a lot of what you were saying about sort of behavioral responses. I mean, yes, it's reduced form. It doesn't have a structural model underneath it, but I think it does get to the heart of what the data tells us. And remember, this is very detailed data, daily data from about, in my data set, about 170 countries. That gives us a lot of information.
Sure. But yes, but what it would be less, I suppose, less useful for is a new intervention that hasn't happened before, for doing impact studies of things that hasn't been tried before.
Yes, but the Oxford study categorizes all of the policies and all of their strengths. So it's very easy to do. I mean, yes, if it's a totally new policy, then you're right. But if it's a policy related to anything that we've presently had or seen anywhere, we can do simulations to work out what the effect will be.
Okay.
Lots of questions. We got a big board going here. Another Peter asks, how practicable is to take adequate account in modeling of the differential clinical impact of a disease like COVID-19 on different age groups, demographic groups, and its effect on personal incentivization to act in the interests of the population generally?
Okay, so let me see if I understood whether to which extent is it practical to do this, and taking into account heterogeneity. Was that the question? Kind of.
Peter Jones, do you want to explore this a little more? I'll invite you to speak. You can unmute.
Yes, essentially, because the impact clearly of COVID-19 is very different in different age groups and different, and to a degree in different demographic groups. So presumably the incentivization to act in a way which is positive from the population's perspective is very different among those different groups. So how does that muck up the analysis, so to speak?
Right. Okay, great. So no, in principle, there's absolutely there's no reason why one can't take heterogeneity seriously. So the kind of models that have been done recently within the economic epidemiology literature typically takes an approach that there are three different categories, maybe very young, middle-aged, elderly, And so people have looked at differential incentives. They might be different. You can also think of it in heterogeneity in terms of susceptibility, or in terms of costs of social distancing. Somebody who, under normal circumstances, who stay at home anyway, you can think of those as people who have very low costs of, very low costs of social distancing, whereas youngsters who are used to go out all the time, they have a high cost of social distancing. So this is something that is certainly important. In fact, I have done some work on heterogeneity. Now, if we turn to economic models, this is completely par for the course. If you have any large economic model and you want to figure out what are the effects of some new measure, such as a tax reform, then we need necessarily to take heterogeneity into account. So this is something that methodologically, certainly something we can deal with, but the economic epidemiological models with the kind of complexity we need for making actual decision-making, these are still in their infancy.
I'd like to invite Giancarlo to join the conversation for a minute, another of Clare's economists, a fellow who's also been working on COVID and what's going on in economies around the world.
Well, congratulations to Flavio, because it's very clear and very on the topic. Now, on the complexity and heterogeneity, Flavio's been working, many people have been working in the department. Since March, I'm engaging with the Federal Reserve Board on this enormous model, where actually one of the problems is to understand layers of age, occupation, and there are surveys about contact across age and occupation. And one of the problems that we had looking at so first of all, we started by saying if Ferguson is right and the disease goes the way it does, there is absolutely no trade-off between economy and health, because that kind of the spread of the disease would have destroyed the economy by creating an enormous problem in distribution, transportation. It would have been like an enormous shortage of supply of people, because they would be sick, they would be symptomatic. So that was like a scenario, not a projection. We made, of course, CNN, because the scenario became a projection, but that is a different issue. But the problem is that the new work is really about the heterogeneity, because contacts, as you know, go down over age within the group of people, but there is also the interaction between groups of people, which is very large for young people, become rarer in the old age, but is still there. And in this group of people, there are particular sector of the economy that can be very exposed. Those are all like the essential workers that cannot work from home. The number of people in essential work that can work from home is very little. And the number of middle management starts to be 40-year-old, and those start to have a significant exposure. And the middle management cannot work from home generally. You need to be on the ground. So one of the aspects of it's a daunting problem, also because there is a geographical location. Flavio is the expert on this, can come back. But there are now attempts to do very detailed and complex model of interaction between the economy and the disease that goes exactly in the direction of articulating by age, occupation, geography. And the problem is what Flavio was saying. There is a disease that there is a strong externality. There's a strong externality, and that is where the problem is, right? People react, but in a way, you need to coordinate. By the way, last thing, also information is important. Part of the public policy is to make sure that information is correct. So it's coordination, it's excessive risk-taking, avoiding congestion, but also information. And on that we can, in my data, counties that voted for Trump meet much more people. The Google mobility is different in counties with prevalence Trump voter than counties in the US that are of a different opinion. This is true also for Brazil, Thiago Cavalcanti and that. I don't want to occupy too much, but just say that the amount of work is boundless. There's almost any time to do anything else from March.
So information and data is important, and Oliver asked a question that touches on that, and it may be just at the start of new pandemic that things are just messy and you don't have enough information. But he says the model said that people would change their behavior because of a changing level of risk. How is this conclusion altered if you consider the scenario in March where testing identified a very small proportion of total cases and therefore the prevalence of the disease wasn't understood?
Yeah.
Do you think this adds more weight to the imperial study?
So this is, so let me answer that in two different ways. So first, there's the issue of asymptomaticity. In the basic model, people know their own health state, but we know that, for example, for COVID-19, 1/3 to maybe as much as half of the population have the disease and can spread it without actually knowing it themselves. So this gives rise to a whole host of issues about people having to make inference about their own health status as the epidemic changes over time. So my daughter, she had strong symptoms of COVID earlier in the year. She had fever, she had all the right symptoms. Now, she was actually never tested, but because, you know, it was not it was not so bad that that became necessary. But we actually never knew whether she was infected. For a long time, I assumed that I had become infected without symptoms just because of my proximity. And so once this scales up to the whole population, you can actually get very interesting things going on where people become fatalistic. They think, oh, most likely I already had it, and so I'm already maybe no longer at risk, and that can change people's behavior. Now, another question is, what do we know about the disease in early stages, and how does that influence things? And this is an incredibly difficult problem that I've been starting to think about, which is one, let's just leave aside behavior and look at a public health authority that has to try to do a cost-benefit analysis based on very, very incomplete data. I think that a sensible policy, which is maybe also what actually was taking place, is to buy time as much as possible to learn about the disease, to see whether this is actually as bad as we fear, but maybe it isn't. The problem is that if it turns out to be as bad as we fear, then it might be too late. So but on the other hand, of course, we can't just close down the whole society just because we do want to run a scientific experiment on the population. So there's a delicate balancing act, on the one hand, trying to contain it while we're learning about the disease, but also not just giving in and just letting the thing rip, as it were. So this is there is a similar kind of thinking within economics. It's called, I think it's called robust control, which is to basically do policy in situation where there's uncertainty about something that describes the environment that you face yourself in. And so this gives rise to building institutions that are robust, that can deal with situations that we're not fully aware of the details. But it also, it also leads us to think about flexibility in policy and being able to change policy at short notice as we learn more about the disease. And I think, in fact, a key issue here is scientific communication, because a lot of the controversy has been about, for example, early on we were told that face masks were kind of not really worth the bother. And then suddenly the evidence changes, and we're told that now we have to wear face masks. And the problem with this is that people who are fundamentally in disagreement with any restrictions will pick on those inconsistencies and say, well, either they lied to us earlier or they are lying to us now. And this is a failure of scientific communication, which is to say to people that this is our best understanding at the present time, but as facts change, so must our approach. And I think there has been a reluctance, not necessarily from the academic community, but certainly from policymakers, being a little bit too bombastic as saying, this is what the science tells us, and these are difficult choices, but really it's the scientists that tell us to do it. And then, well, the science changes, and then what?
Thank you, Flavio. Martin, I think that answers your question, really. Martin agrees with you that I'm being overly optimistic and hoping this is once in a century, and this is going to happen again, and that you have the Trump-Fauci dynamic. And, how do we get more on the side of Fauci, to put it simply, I think. What institutions?
Actually, about a year and a bit ago, I was invited to participate in a simulation in the International Monetary Fund, where they had a fictitious, there was kind of a role play type of thing where they had there was an unidentified new disease, the outbreak in somewhere in Asia, and it was spreading across the world. And basically the simulation was about what are the economic fallout from these things, and should the fund, the International Monetary Fund, should they actually take this kind of scenario into account when it decides whether or not to carry out specific policies. So there are some people who saw this coming, even as recently as last year, but epidemiologists, they don't tire of telling us that this is something that is bound to come back. And in fact, we might actually have been lucky, because there are other configurations of the disease that could have been much, much worse. It could have been much more infectious. It could have spread much faster. It could have had much worse effects. I mean, this time it's the elderly. And so many people are a little bit callous and say, well, the elderly are going to die anyway. Next time it might be the kids that are at risk, okay? And that, that's going to concentrate minds in a different way. And so I really think we should be careful in just thinking this is just a one-off. And yes.
Okay, so still got a few more questions coming in. I think we advertised this for about an hour, but Flavio, you're okay to go on for a few more minutes?
Fine. Yeah,
okay,
yeah.
Great. So I'll just pick another one here. I'm getting lost in the number of them. Lars asks, have you empirically validated the claim that accounting for behavior yields better models? Can such models fit historical data more accurately? Are they better able to predict later spread when extrapolating from early data?
So I'm a theorist, so I don't do almost any empirical work. There have been lots and lots of very sophisticated empirical work. I think it's not an understatement to say there have been literally thousands of papers produced on actual behavior, and some of them are fairly successful, yes. But again, a lot of this research has been created in a rush. There were papers sprouting up every time you left your front door. You were a few new papers thrown in your face. And so I don't know which one is like the leading candidate, but there's certainly lots of serious work that has looked at this. And so I'm I'm a theorist, which means I like to think about concepts. I like to think about relationships, about effects in a fairly abstract way. But there's lots of very excellent work going on right now. For example, the person I mentioned earlier, who did the empirical work on the Eat Out to Help Out, has already magically produced a paper looking at the Excel glitch of the test and trace as a natural experiment to see what are the effect of that glitch on the number of infections, because we didn't test and trace for those people as rapidly as we otherwise would have. So there's really an incredible amount of new research, and unfortunately, even though I'm a contributor to this, I find myself always falling behind as a consumer. It's just not possible to absorb all that new research.
A couple more questions here. You mentioned the importance of federal governments incentivizing local governments in view of flattening the curve and ensuring strong economic recovery. Are there particular policies or even federal municipal fiscal framework reforms that you think might streamline conflicting approaches jurisdictionally?
So let me answer a different question that goes along. So rather than thinking in terms of fiscal reforms, let me think about just in terms of disease control. So my belief, or my strong conviction, is that a good policy for combating the disease is one that is sensitive to local conditions, so that it is regional in nature, but coordinated centrally. So what I mean by that is, let's take a toy example. Suppose that in Gibraltar there was lots of infected people. Would we do a national lockdown in that case if there was no problem in the rest of the UK? Certainly not. We would say, well, this is a localized problem, let's deal with it there. But by the same token, if you have regions that are interacting locally, you cannot do disease control that is in one region that is disconnected from what happens in other regions. So for example, within the UK, we have an advantage relative to, say, the US, where in the US, disease control measures are largely decentralized to the state level. And so what you have there is that depending on who is governing a particular state, you can have very strong measures or very weak measures. And of course, because of these external effects, they have strong externalities on each other. And that's, of course, counterproductive. You need to take into account how these different units interact. And so, again, the two keys here is that it has to be sensitive to local conditions. Okay, you want to spend your resources where it's most useful. I like to think of it as a firefighting metaphor. You know, if there's fire in a specific place, you put out the fire where it's worse or where you think it might spread next. Okay, and that's, of course, the second part, that you need to coordinate those two things in a sensible way.
Thank you. An earlier question that relates a little bit to how different things happening in different parts of the world affect our behavior, I guess. Stronger restrictions may signal more serious danger. When Danish people started to reduce risk exposure, there were some countries like Italy already in lockdown. People could have assessed the COVID-19 risk based on this kind of information. Is there a synergistic effect between public policies and individual behaviors based on risk perception, and then how we perceive risks, you know, things happening in other places?
So it's certainly true that people learned from other countries. Mistakes were made early on, which was inevitable because we didn't understand the nature of the disease. So for example, Italy was unlucky in being one of the earlier ones. One of the mistakes I think was made there is that everybody who had COVID were basically put in hospitals, and therefore very early on, people who had maybe not even very strong symptoms, they maybe clogged up the system and made it very unwieldy. So this is clearly something that was not repeated elsewhere. But it's clear that that when different countries they had, on a different time scale, other countries learned from that, and the risk perception also changed that. But one thing that I'd like to come back to, which is that different countries have taken different approaches. And I think in some sense this is wholly appropriate. The reason is twofold. First of all, countries are strongly heterogeneous. Some countries have an older population than other countries and therefore are more at risk than other countries. Some countries have higher population density, which means infection control is just a completely different game in those countries. Again, countries like Brazil that has a very large populations in poverty, that live in very close quarters, maybe in multi-generational households, social distancing in those places is just a completely different thing that it will be in Finland, where people have much more space and maybe people don't live in large families. So the natural differences between countries dictates that there should be different approaches. The second thing is that there is ideology. People have just different political ideas about what is acceptable and what is not acceptable in a given context. And the last thing I want to say is that in some sense, the different policies in different countries is a giant science experiment. Because people have not known exactly what was the right thing, in some sense, it's desirable that different countries do different things because it has allowed everyone to learn from each other. We don't want everyone to do the same wrong thing. And in some sense, if a country has messed up, the rest of the countries can learn from that experience. Right now, of course, the poster child of a great policy is New Zealand. And we understand that what they did in New Zealand is that they had strong restrictions, they kept the numbers down, that allowed test and trace to work efficiently. Of course, as infection numbers go up, test and trace becomes unwieldy because there are just too many contacts to keep track of. So that is a combination, travel restrictions and so forth, that has worked well, and we now understand that. Had New Zealand not done that, we would have been, poorer in terms of information and in terms of knowing what works and what doesn't work.
So Flavio, one last question. It sort of looks at where your slide was ending, and it's the last question that was put here, which is looking at the next part of the experiment. So more and more vaccines are claiming to be 95% effective, even though they have not yet been peer reviewed. An increasing amount of people in populations are becoming wary of actually getting the vaccine. How will this affect the curve? And then, how are economists talking about the incentives you talked about to really get people thinking about, getting vaccinated?
Okay, so first of all, the vaccine. I mean, I'm not a medical scientist. We are being told that that no corners have been cut, and I don't know. I'd like to think that this is true. I don't think. I think it would be extraordinarily callous to roll out hundreds of millions of vaccines if you really had cut corners, because it would be potentially it would be an existential risk for humanity if that were the case. But there are things that we don't know, whether the effect of the vaccine wanes over time. This is just, we haven't had time for that. So we might have to revaccinate the population every so often. So there are lots of things we don't know, but this is completely outside of my area of expertise. What I do understand is something to do about incentives. Vaccines are one of those instances where there are positive externalities, and so there's a prima facie case for incentivizing people to take those. So there's in principle nothing wrong by saying to people, if you get a shot, we are going to give you something along with that to encourage that kind of behavior, because it has these strong positive externalities on other people. There is another issue, which is that as people become vaccinated and the disease subsides, it might actually disincentivize others from getting vaccinated. So there is always going to be some of that if I do it, then I can't infect you, and of course you have a weaker incentive to do so. But I think to some extent, businesses and cultural norms is going to take care of that. So there are already airlines who have announced that if you want to travel with them, you have to show them a certificate that you have become vaccinated. Okay, so I think that in some sense, the argument that the non-vaxxers are using to refuse to get vaccinated is an argument that we also can use. In the same way that they don't want their personal freedoms to be infringed upon, but we can also insist that we have the freedom not to interact with those people. And so if you want to come into my business, you'd better be vaccinated. If you want to come to travel with my airline, you have to be vaccinated. So of course, in a free society, we are also free to determine who we want to associate with. And so in the same way that sometimes you can't take your dog into a restaurant, in the same sense, you might not be allowed to come into certain premises without a vaccine. And there's historical precedence for that. I know that in Australia, for example, if you want to send your kid to a state school, then you need to be vaccinated. And if you decide, because of your own convictions, that you don't want to do that, that's of course that's your privilege, but of course that curtails what you're allowed to do in our society.
Thank you, Flavio. It was certainly that way growing up in the US, but I imagine some of those things are getting eroded in certain jurisdictions. Flavio, there are no more questions. A lot of people have said thank you. Giancarlo had one more observation. He said, the announcement of a good vaccine coming soon should also raise the incentive not to get infected now, hence take more costly precaution. Flavio made this point on a website.
That's right. So if you're interested in that kind of thing, we just released, was it yesterday or today? I'm so tired now that I forget. We've just released a column in Vox EU that makes exactly that point. Just because the vaccine is on the horizon, that's not a license to cash in now. As we say in Denmark, you can't sell the skin before you shot the bear. And so what we really want to do is we want to redouble our efforts, and we want to get to the point where we can actually get the vaccine, because once you're infected, it's too late to get vaccinated. So that's right. We are at the final stretch, and we have to get there safely.
Thank you, Flavio. Thank you all for participating. I just want to, for those who are still here, just tell you one quick thing. Rates in Cambridge spiked a little bit, but they've come right back down at the university. And the testing has been working really well. And we're kind of our own little experiment in terms of carrots and sticks and so forth. And papers will be written about it. But the good news is things are going well at Clare, and we're going to get to the end of this term successfully. So thank you all. Be well.
Thank you all for coming. It's a pleasure.